So this session is on health and communities, and you can see it flows very, very well from what we've just heard. Our speakers, I'll do the same as I did last time, and that is do a general introduction now and then just let them follow one after another. I think that there's a little more time we've allowed for audience questions after this session, so we'll take advantage of your expertise and feedback to the speakers as we go. So our speakers are Bernie Shakeshaft, who is the founder of BackTrack Youth Works in Armidale, Sally Redman, who's the CEO of the Sachs Institute, Elizabeth Elliott, who's a distinguished professor of paediatrics at the University of Sydney, and Maree Teeson, who's professor and director of the Matilda Centre for Mental Health, also at the University of Sydney. So, Bernie, you first.
Gee, I was pretty disappointed to see that I couldn't find cowboy hat, work boots and jeans, but anyway, here I am, wearing my tie with the paw prints. Bernie Shakeshaft, came from a loving family, big Catholic family. School was probably the toughest patch of my life. It didn't work out. If I went to school today, with what I know about the education system is, they would say you got that ADHD thing, can't sit still. Dyslexic, oppositional behavioural defiance disorder for sure. And Tourette's probably would make a lot of sense to my mum. I think my final year at school, I spent that much bloody time in the principal's office, I was starting to think I might be the principal. Had my own desk there. You know, I go, if I couldn't make it through that system, then the kids that we work with now, we've heard that word disadvantage a bit today, how the hell are they going to get through it? Probably going to be a little bit controversial, some of the things, my opinions, but this is just my lived experience. I look at technology 150 years ago and I look at where it's up to today and I go, they are worlds apart. If I look at transport 150 years ago, where it's up today, worlds apart. If I look at education 150 years ago, and where it is today, sorry, I'm not a scholar, but I don't see a whole lot of difference. 20, 30 kids sit in a classroom, sure there might be a computer screen and do things different ways, but everyone's going to learn the same way. And if it's not working, Einstein's definition of insanity, keep doing the same thing expecting a different result. I find that pretty disappointing. I think regardless of where you grew up, your level of education, your chosen career path, you might agree that as big people, one of the most important jobs that we have is to raise happy, healthy little people. I reckon that children are the most honest barometer of how we're going as a society. Mental health, 1 in 3 kids in Australia have a diagnosed mental health condition, 1 in 3. 40,000 homeless kids tonight. I was going to say 1 million people living in poverty, but then I heard Her Excellency say it's actually 3.3 million, so I'll stand corrected there. How about suicide being the leading cause of 15 to 24-year-olds in Australia? Suicide. 2014, Dusseldorf put out a report. This is in 2014. You know the federal law says you must be at school until you're 17, or you have to be in a job. 2014, they estimated 1 in 5 kids under the age of 17 doesn't go to school, is not involved in training, and certainly doesn't have a bloody job. Now, when we started in 2006, we were dealing with 16 and 17-year-olds, in and out of jail, certainly not going to school. All our referrals now are coming at 10, 11 and 12. We are seeing kids not make the transition from primary school to high school. Where does that end up? We value education, but we have to do it a different way. Have we got a different way? Hell yeah. Going to have a look at that in a minute. How about locking people up? 2013 to 2018, the UN data looked at every country around the world and measured growth in incarceration rates. Colombia coming first. Turkey, hot on their heels, coming second. Guess who's coming third? The lucky country, Australia. Righto, on average, 956 kids are locked up each night nationally in Australia. There are another 5,000 on community service supervision orders. Do you know how much it costs to keep one kid in incarceration in Australia? $700,000 a year. That's the average. A bit more in some states, a little bit higher in territory. When we start to do the numbers on that, pretty straightforward, $2,000 a day, 956 kids, $2 million a day we're spending, because that's the best damn solution we can come up for finding a 10-year-old. That's what age we lock kids up in Australia. 10 years of age, we start locking kids up, and we're prepared to pay $2,000 a day to create a problem that you know is going to come again. There's the stats on it. 80% of kids reoffend within 12 months. What are we doing, Australia? The lucky country? I don't know. Look, if this stuff was working, I say well and good. But if it isn't, then what are we doing? For me, I go first world country that I live in. I think feels like a national shame in many parts of it. We're tipping so much money into things, but it's not working. So easy to define the problems. It's probably the easiest part to do. We can go on about that all day, but what's the damn solution? So 2006, I made a decision in my life. I go, either stop complaining about what this problem is or go and do something about it. I chose to go and do something about it. So we started BackTrack Youth Works. No business plan, no funding, just a busted shed and some busted kids. How did we get that busted shed? The community, council, Reshaping Australia, Communities in Action. Day one is where it started. Our council gave us a shed, peppercorn rent. And we started grinding away with the kids most at risk in our society. So, I didn't know all that fancy stuff was there. It's good to have good people in it. Who are the kids? Almost 100% of the kids are already removed from the education system. They start at 10 years of age. They're often kicked out of home. They have substantial contact with the legal system. Some have already been locked up. Mental health, drug and alcohol addiction, poverty, multi-generational unemployment. 75% of the kids are Indigenous. All come with severe psychological distress. These are the kids society has let down. They've fallen through the cracks. They've been kicked out of everywhere. So, what is BackTrack? There's three components to it quickly. The first one is where we work with the young kids. It takes us about 12 months usually just to sort out legal issues. We've got our own school teacher. We provide a different level of education. We start doing practical hands-on training, stuff that we know will make these kids employable down the track. How do I know that? Tell you what our data says. 87% of the kids that we start with, get this is the kids that no one else in society will work with, 87% of them end up in jobs or back in full-time education and training. Very first kid that was referred to us, Indigenous kid. He was the 8th kid in his family, so the youngest, all boys above him, single mum. School principal gives me a ring, Bern, would you come and have a chat with this kid? We're about to kick him out of school, expel him out of school. Once you're expelled from school, things get really tough, yeah? So I said, yep, happy to come and have a talk with him, but what are you expelling him for? She said, well, he was trying to throw a chair out the window of a 3rd-storey building. And I went, seems pretty savage you're going to expel a kid for trying to throw a chair out a window. She said, oh, Bern, the teacher was still in the chair. Let me go and have a yarn with this lad. I know the family. I go in there, I go, champ, what's your dream? I watched him squirm for 2 or 3 minutes and he went, you know what? He said, I want to be the first kid in my family to finish year 10 and not have been locked up. Can we help with that dream? The quicker they kick him out of school and he comes and walks alongside us, and the quicker we'll do something about that. That kid went on to finish year 10. He then went on to finish year 12. He's the first BackTrack kid to ever go to university. Lasted about 3.5 minutes, but he got there. He's now been in employment. None of his brothers have ever had a job. He works for us. He's one of our supervisors and he gets what we're doing on the ground. That's the first bit. BackTrack just keeps filling holes in the thing, yeah? We get these kids into jobs. A lot of them get sacked after a month or 2 months. They're back with us. We're on this revolving door. What are we going to do about that? There's plenty of employment agencies. I think 10 of them in town. These kids don't go there. They're not helping those kids out get a job. I tell you what we'll do, we'll start a for-profit business, but we're only going to employ unemployable kids. How's that for a business model? Lunatics only. Since then, we've had 56 kids employed, and they stay with us for as long as it takes till we move them on into full-time employment that they can hang on to. Of the 35 young people we have employed at the moment, I think 90% of them are Indigenous. You want to talk about closing the gap, come down, visit us in Armidale, but you can't find a gap. 35 kids, 26 of them are on traineeships, and we have an 88% completion rate. Do you know what the state average is? Low 40s. Is it easy? Hell no, but we're hanging in for the long haul, and it works. The last bit, is this stuff replicable? Can you scale it? Or is it just because it works in Armidale for some crazy reason? Well, when we start involving communities, I can tell you in Dubbo, Lake Ageligo, Broken Hill, Maree, Hawkesbury, Maxwell, Tenterville, and now Toowoomba are the towns that we're working in. And guess what? All get the same results in a really short period of time. Only 2 local government areas in New South Wales with long-term juvenile crime stats going down. 6 of the universities that are in this room did this research. This is not me making stuff up. You can read it. It's all published. I think it's Tweed Heads, Toowoomba, not Toowoomba, up on the border somewhere is down 2.2%. Armidale down almost 50%. Long term. So 10 years before we started, they looked at, everyone went, oh, it's because we've got extra cops and extra cameras in the mall. The beauty of research is they checked that with 20 other towns and went, you know what, you've all got extra cops and extra malls. How come these guys' crime rates are down? We know how to do it. We take them out of town Friday and Saturday nights, times of high risk. Same stats right around the countryside. 80% of the damage will be done by 20% of the kids. Concentrate on that 20% of the kids, and hey presto, guess what happens? We don't need Einstein to work this one out. Lucky enough in 2014, so the kid that didn't finish school, the university actually just recently gave me an honorary doctorate. When they rang me, they said it's an honorary doctorate. Don't clap, just throw money. Gave me an honorary doctorate in lettuce. And I went, in lettuce? This is good timing because those iceberg things are $12 each. Not lettuce, you idiot, letters, whatever that means. 2014, lucky enough to get a Churchill Scholarship, travelled right around the world, wanted to look at organisations punching above their weight. And what is the similarities? 7 simple things. Long term. We're not doing a 26-week program. Must be long term, and you've got to do whatever it takes for as long as it takes. Holistic in nature. Don't just concentrate on mental health. Don't just concentrate on education. You've got to look at the whole big picture of what's going on in these young people's lives. Multiple funding sources. What's our budget this year? Just short of $7 million. Less than 5% government funding. $7 million a year. If one of those funders leaves us, we don't sink. Must fill a gap in the system. Don't replicate what somebody else is doing. Come up with some fresh ideas. Interesting one, didn't matter how much the self-generated income was, but they all had self-generated income. Embedded in the community. Takes a village to raise a child. Want to travel fast, travel alone. Want to travel far, travel together. All embedded in the community. An effective evaluation. I'm going to skip through this because we're running out of time, but have a quick squeeze. First year at BackTrack, all legal stuff, mental health all over the place, general stability. Are they interested in education? Are they interested in employment in the first year? Not one little bit, but have a look in the third year. And now we're not going to court anymore. The mental health stuff's good stability. They're interested in education, so long as we bring a different style of education to the table. And then employment. They want a job. This is the 5% of kids that society's given up on that cost us, what do they call them, the $1 million kids? And we turn it around with about 150 grand a year. What does the research say? Good engagement strategies. We call it circle work. It must be real. It must be meaningful. We talk about the hard stuff out there in the paddocks. If I ask most of the people in this room, they'd get pretty squirmy if you listen to the conversations we have. What happens when you die? What's your dream? Do you know how to fix this piece of shit in your life? And then we start making real traction. Case management, I'm not a big fan of it. Our kids go, you go over to that office, that's where they sort the hard shit out, eh? Yep, we call that the sorting the shit out office. Diversionary activities, Friday, Saturday nights, get those kids out of town. We use dogs, doesn't matter what you do, but get them out of town. There must be a personal development. The Hunter Medical Research Institute says the return on investment is over $2 for every $1 invested, all published, published journals. I'm going to leave you quickly with one simple notion that we've used, and we've taken that from Canada. It's called the circle of courage. They say whether it's your personal life, whether it's your organisation, whether it's your whole town, you get these 4 simple things in balance and everything will be going well. First one, and I've heard it here many times this morning, belonging. You must feel connected to something. The second one, independence. You have to have a say in your life. The kids at the shed go, we call that owning your own shit. Pretty good concept. The third one, mastery. Doesn't matter what you're learning, so long as you're learning something. And the last one, generosity. You must give something back. And that's what our kids do so beautifully.
Thank you, Bernie. It's an inspiring story, which I'm sure will guide us through our discussions as we continue. So next we have Sally from the Sachs Institute, who'll pick up on the mental health stuff, I think.
Hi, everybody, and thanks so much to Susan and Stephen for the opportunity to speak this morning. It's a great theme, and the presentations so far have been really fantastic, and it's terrible to have to speak after Bernie. It was such a great presentation, so thank you. So look, I'd like to start by acknowledging the traditional owners of the land that we're meeting on today, the Gadigal people of the Eora Nation, and to pay my respects to elders past and present, and to the Aboriginal people who are here today. Now, I'm famed for not being able to work these, so... I can probably help you out of here. Yeah, good, I'm stuck. This one? No, the green one. The green one. Big one. There's an enormous green button. You would think it would be obvious. So. Okay, so I wanted to talk this morning about co-production, sometimes also referred to co-creation or co-design. And I wanted to give one long-term example of my experience in being part of a co-design project. In co-design, it's often quite different to how researchers think about running a research project. They often talk about collaboration. But in co-design, the stakeholders like communities are integrally involved in all aspects of the research, generating the ideas, undertaking the research and interpreting the findings. So it's a much closer way of working. It's a different way of working, and I think it has the potential to draw on the expertise of communities about their lived experience, as we've heard already today, and to really, importantly, to mobilise partnerships for action. And again, we've heard some great examples already. I think critical and at the centre of co-production is the sharing of power, a great a recognition that everybody is bringing different but equal expertise to the table. That can often be challenging for us as researchers. It's not the usual way of doing business. It's not easy, requires time, resources, commitment, and of course not all research is amenable to a co-production approach. But I wanted to talk today about some work we've undertaken, I've had the privilege to be part of, with urban Aboriginal communities. It's been going on for the last 20 years in New South Wales, so it's a kind of long-term historical look at some of the things that can be done using this approach. And I think many people today have recognised the importance about long-term commitment and working with communities. I wouldn't want to suggest that we're the only people who've done this. And of course, the Indigenous leadership of this work was really important. So I'm slightly embarrassed to be the person who's up here talking about this today. I particularly wanted to talk about Sandra Bailey, who at the time we started this was the CEO of the Aboriginal Health and Medical Research Council. For those of you who are not in health, this is the peak body for Aboriginal community-controlled health organisations in New South Wales. It plays a really important role, and those health services are really critical. They're often the hub in their community. They have a governance board made up of elected by local community members, and they provide really holistic care. So, particularly in urban areas, they're a really important component of Aboriginal communities. So, I also wanted to recognise Professor Sandy Eads, who'd be known to many of you as an Indigenous research leader. She was the initial study director for this work that I'm going to talk about. And obviously the CEOs and the staff of the Aboriginal Community-Controlled Health Services were really fundamental and wonderful leaders. I learnt so much during the course of this project. So I think, and we're going back 20 years now, makes me feel quite old. At the beginning of this work, relationships between researchers and Aboriginal communities in New South Wales could only be described as poor. The feeling of many Aboriginal people that we spoke to at the outset is really nicely summarised in what I think is this very powerful quote from Pat Anderson. She talks about the fact that research was done to Aboriginal people. We probably even use terms like subjects, for example, although obviously that wasn't limited to Aboriginal people. We didn't talk about doing it with Aboriginal people, and certainly not the research being done by Aboriginal people. And I think the most important part of this quote for me is that despite the fact that there was research happening, it wasn't resulting in any improvements in health or services, and I think other people have reflected on that today as well. So, you know, at the beginning, about 20 years ago, in discussions with Sandra Bailey, it was really evident that the Aboriginal Health and Medical Research Council wanted to do things in a different way. They wanted to see Aboriginal people playing a leadership role. They wanted real outcomes, and they wanted something that built capacity. You know, she was really way ahead of her time in describing an approach that we now refer to as co-design or co-production. Through her leadership, a collaboration was formed with a group of really committed researchers and 4 Aboriginal community-controlled health services. We asked them what did they want to know about, you know, how do they see research could be useful. I'd imagined we'd start on something quite simple, but they wanted a long-term study of child health that would help identify opportunities to improve health and particularly to prevent health problems developing. So we got started, and obviously Sandy Eads was really important in helping us attract funds for this work. But we spent a long time at the outset establishing a governance framework, remembering that this was quite early days. So it was important to ensure that the ways that the researchers and the health services were going to work together was concretised, if you like, it was cemented, that there was strong governance around it, and that they were clear that they had the opportunity to lead decisions in all aspects of the study. And I think, you know, really importantly, then and now, is the agreement about how data will be managed, and Kalinda made some very important points about that. But I think, importantly, they wanted ownership of the data and to ensure that nobody could publish it without the ACCHs having signed off. This is quite radical and kind of threatening for some of the researchers, but a really important principle. And also the study staff were employed by the Aboriginal Health Services, and again, that was really important. So we kind of set to work. We built a cohort of 1,600 urban Aboriginal children. So I should say that in New South Wales, there's a very high rate of urbanisation of Aboriginal kids, and most of the research at that time was focused on rural and remote Aboriginal communities. We followed them over time, and we together were able to provide some of the first data about housing, ear health, mental health, physical activity, many aspects of health and well-being and its causes among urban Aboriginal children. So the interesting part for me was that although the health services were interested in the data, they were much more concerned about how we could use them to bring about change. So, as researchers, we often sort of talk about that, but for the Aboriginal health services, that's why they were in the research process to start with. So we're just getting started, really, once we saw the data emerge. Together, we were able to use our networks to attract better services for participating Aboriginal health services across many areas, including mental health and housing. I thought I'd just say, in particular, we had a lot of success in trying to improve services for ear health. A lot of these children also had the same kind of hearing losses that we see in rural and remote communities, and obviously that leads to development and speech delays, which impedes progress in education and reduces employment opportunities later on. So because the data from the study were powerful, we were able to attract funds for about 8,000 speech pathology sessions, and we were able to encourage additional and support additional surgery, ENT surgery, to ensure that all Aboriginal children from who are part of this larger in the urban area were offered ear surgery if they needed it, and completely cleared the waiting list for those areas. But perhaps even more importantly, the Aboriginal health services, which is so important in their communities, were able to use the data to improve their own programs. So in one service, for example, they attracted funds from audiologists because they could demonstrate that hearing loss was an issue for them, and they also have the most fabulous state-of-the-art room for testing hearing. They also use it to lobby the local schools and preschools to help them understand why children weren't able to perform, and were able to establish better programs for those children, acknowledging the hearing loss and speech delays. Based on the diet data, this AMS began delivering fresh food boxes. It set up a community garden and banned sausages at the community barbecues, which was really I think probably one of the harder things that emerged from the study. So what about the co-production effort? So I just wanted to end by talking a little bit about this, remembering that this was going back some time ago. When we talked to the staff of the Aboriginal Health Services about how it had been to be part of this project, they talked about how important it was that we'd focused on outcomes, not on the research. They wanted to know how we could use data to change things, not just to study them. They talked about the fact that there'd been a genuine respect and valuing of different expertise, and almost everybody who's not Indigenous associated with this project, really learned so much from being part of it, and that we put in place and adhere to strong governance and shared decision-making processes. And it was interesting that the staff at the AHSs valued the fact that the team came back, that we chatted over coffee, that we came to barbecues even when the sausages were stopped, and participated in other community events. It sort of struck me that, this is the same kind of processes that I would use to build relationships with any people who I valued and who were my colleagues. And so that was the fundamentally most important thing, I think. Perhaps also an important part of this is that 2 decades later we're all still working together. And I thought, Bernie's comments about long-term were really important. You can't do this overnight, because at the heart of it lies, kind of the concept of trust, which isn't something that you can do quickly. Indeed, our collaboration has grown, and there's now 9 Aboriginal community-controlled health services who are part of this work, and we're working together on a much broader range of issues. So I think, to feed into the discussion today, it's kind of easy to talk about co-design and co-production. We really all recognise the importance of it. Doing it has to be a long-term endeavour. It's hard work, but I think the benefits are absolutely huge. So thanks very much for the chance to speak.
It's the long term, as you say, but it's also the humility of the process. It's participating in these things genuinely with other people. I think that's a really important thing I've seen from both of these presentations so far. So now on to our paediatric specialist, who is going to talk about... Sorry. Okay, thank you.
Thanks. Thanks very much, and I'd like to start by acknowledging the traditional owners of the land on which we meet, the Gadigal people of the Eora Nation. When Australia signed the UN Convention for the Rights of the Child back in 1990, we made a commitment to the future of this country. We agreed to promote and protect children's rights to survive, thrive and prosper, regardless of their race, religion or ability. We acknowledge that all children have the right to good health and good health care. As a paediatrician, I know the benefit of a good, healthy start to life, not only for child health, but for adult health and well-being, and indeed the prosperity of the nation. I concur with the National Aboriginal Community-Controlled Health Organisation that health is not just physical well-being of an individual, but their social, emotional and cultural well-being, and that individual health requires community health. You might think that Australia has achieved our goal of child health. We have low mortality, 95% of kids are vaccinated, we ventilate tiny babies, cure leukemia and transplant livers and hearts. But challenges remain, and we've heard of many of those this morning. 1 in 10 children has a disability, 1 in 4 is overweight or obese, 1 in 5 has a mental health problem. But most perplexing in this wealthy country is that so many children have been left behind. And after this morning, you can guess who they are. They include the 1 in 6 who live in poverty, children in remote locations, Aboriginal and Torres Strait Islander children. Think also of the sombre findings from recent royal commissions and inquiries that have sent shockwaves through our communities. The inquiry into institutional sexual abuse, abuse in juvenile detention, domestic violence, and children in immigration detention. These leave us in no doubt that we have a long road to travel, and above all, that governments must fund the recommendations of these inquiries, not more inquiries. But they've also sparked powerful community-led initiatives that have influenced government, driven legislation, garnered public support, and have tipped the balance for action for some of these wicked problems. For over a decade, I've been very privileged to have worked in very remote communities of the Fitzroy Valley in Western Australia, where health gaps and their underpinning risks are laid bare. I suspect few of you have visited towns like Wonkajonka, Yakanara or Nunkamba, or heard the languages of the Wallamajori, Gooniyandi and Bunaba people. Few could imagine that Australians there could have a life that was so different. But this is a place with strong culture, strong leadership and strong communities. In 2008, the courageous Aboriginal women were so worried about the harms of alcohol that they lobbied for community-led alcohol restrictions, which persist today. In 2009, they became concerned that alcohol use in pregnancy was damaging the next generation of children, and they developed the Maree strategy to identify and prevent fetal alcohol spectrum disorder. Maree is a word in the Bunaba language that means precious, worth nurturing, which is what they felt about their children. They invited our team to partner with them, and this was a project, Sally, that was co-designed with the Aboriginal communities. Together we did the Lililwan project, and we found that half of the primary school-aged children had been exposed to high levels of alcohol during pregnancy, and 1 in 5 had fetal alcohol spectrum disorder associated with severe learning and behavioural difficulties. Aboriginal women then presented these very difficult truths to their communities, to governments, to the UN Forum for Indigenous Issues, and to parliamentary inquiries, and they lobbied for funding and services. 10 years on, Manamundukura, the Women's Resource Centre, which is a community-controlled Aboriginal organisation led by Emily Carter, now has a child and family centre integrating early education with maternal and child health care. They have a support unit for families with FASD, a parenting program, a domestic violence shelter, legal aid and a social art enterprise, and they're leading ongoing partnerships to develop optimal models of wraparound care for health and well-being of children and youth. but they still lack long-term funding. Aboriginal leader June Oscar, who's now the Australia's Social Justice Commissioner, said, in the Maree strategy, Aboriginal and non-Aboriginal people achieved great things by working together, and in the process, we came to understand each other's worlds. She also said, our journey has taught us that Aboriginal people must take control. We can change what is happening in our communities. So, when next you read the media piece of the suffering in communities like ours, don't think of us as victims. Rather, support us to be the architects of our future, a future in which every child has the right to be born healthy and fulfil their potential. Similar communities are tackling other preventable conditions, dental caries, scabies, acute rheumatic fever, trachoma, through practical initiatives, healthier housing, access to washing machines, dental programs, and maternal health literacy. In 2014, as a consultant for the Australian Human Rights Commissioner for the inquiry into children in immigration detention, I had the opportunity of visiting Christmas Island and meeting many children there and from Nauru. 1/3 of those children had severe mental health problems. I recall one young girl crushed by layers of trauma, an absent father, the boat trip, a hostile detention centre. She'd stopped talking, eating and drinking, a condition called resignation syndrome. And in a note to us, she wrote, "My life here is really death. If I go back home, I know they'll kill me. Better I kill myself." But there was no access to reasonable health care, no child psychologist or psychiatrist. Specialist consultations, some 3,000 kilometres away, were delayed for months. The initial 2014 Human Rights Report, initially dismissed by government, confirmed that detention causes harm to children. But above all, it gave these invisible children a voice. That voice was then amplified by community advocates, health professionals and the media. Do you remember the campaign, Detention Harms Children? Community pressure assisted in the eventual release of all children from offshore detention centres, though sadly many still languish in the community on temporary protection visas or awaiting assessment for refugee status. Arbitrary detention is illegal, and we must reconsider how Australia can better treat the next wave of children seeking asylum. NGOs have also had an important role in coordinating coalitions of community voices for change. For example, the Foundation for Alcohol Research and Education pushed for labels on alcohol to warn about the harms of alcohol use in pregnancy, and these come into force in July of next year. The parent-led group Rare Voices Australia has achieved a national plan for rare diseases, which is endorsed and funded by government. The campaign to raise the age of criminal responsibility has recently gained some traction in the Northern Territory and the ACT. Policies from paediatricians at the College of Physicians have alerted governments both to the inequities in child health and the impact of COVID and the need to act. So many communities are standing up to inequality in child health, and now we need action from government. Thank you.
Thank you so much, Elizabeth. They were inspiring examples. Now we're going to hear from Professor Maree Teeson from the Matilda Centre. Thank you.
Oh, sorry. Thank you very much, and thank you so much for putting me in between these people and lunch. So excited about that. I just want to acknowledge Her Excellency the Honourable Margaret Beasley ACQC for inviting us into her amazing home. And Stephen and Susan for your kind invitation, and to acknowledge the Gadigal people of the Eora Nation. We are honoured to meet on your lands here today. So it is absolutely wonderful to be here today, and the theme of the day is Reshaping Australia, Communities in Action. And if there was ever an area where we needed to do that, it is in mental health. Before I talk to you about some of the work that we're doing in this space, I just want to share a little of my own journey with you. So Bernie, I was first in family to university from an incredibly disadvantaged school. We didn't throw teachers out the window, but I can tell you how many teachers' arms we broke, not me personally, as they came into the room because we didn't want to be taught. So education and its transformation is incredible and incredibly important to me personally. Now, my first research job, out of the frying pan into the fire, was not very far from here in Darlinghurst. I was 22 years old, so not much older than this person in the picture. So I really want to bring that youth voice into this conversation because for mental health that is going to be incredibly important. I was a newly minted psychologist, and only 500 metres from my office, a young man, not much older than me, named Jonathan, had died alone from a drug overdose in a refuge for the homeless men. He was also living with schizophrenia. Jonathan was fiercely loved, and he was supported by his family and his community. And I know this because Jonathan's mother was Anne Devison. She was a leading Australian human rights campaigner and the journalist who wrote the book, Tell Me I'm Here. And she became, for me, a fierce ally for change. So that book and connection really changed the way I thought about the research and what I wanted to do with my life. Jonathan taught me that two very important lessons. One, drugs and alcohol and mental health and all of these issues often occur together in incredibly devastating ways, and that we need to pay attention to that connection. He also taught me that we will always be playing catch-up if we don't focus our research and our work and our energy on prevention and early intervention, and how incredible have some of the presentations been today about doing that. And that a mentally healthy future for everyone will really require a whole community approach, encompassing individuals, families, support, and wasn't it amazing to hear about housing today? So, 30 years on, and I'm really sorry to say our world still holds incredible darkness when it comes to mental health. Too many Australians die by suicide every year. Over 40% of young people in Australia have experienced mental disorder in the last 12 months, and those rates have doubled in the last 15 years. The shadow pandemic is real and it's unacceptable. Every week, a mother or father calls me because they're in an emergency department that is not a good place to deliver mental health care, with a distressed child who is cutting themselves so deep that they have to have stitches every week. And we know that mental disorders cost the Australian community $50 billion annually. I think Bernie particularly made that point, that suicide is the leading cause of death in Australians between the age of 15 and 44 years of age, and that more young Australians take their own life than die in motor vehicle accidents. And what do we do about it? Well, we not only have a pandemic in Australia, we have in mental health a plandemic. We have an absolute plandemic of inaction. Since Jonathan died, there have been 53 major inquiries, a lot of them royal commissions. So 55 major inquiries, and we have failed to implement every single one of them. So let's just not, I wish we had at least implemented all of them, but no, 55, and we have not implemented any of them. So we definitely need a change, and we're going to need some different change agents to do it. And we will need that change to reshape Australia. So there's going to be many ways to do it, but one of the ways that we're working on at the moment is establishing an innovative and a unified voice which is focused around action. And that is going to be made possible by partnerships with philanthropy, including BHP Foundation. This think tank, we're working to connect research, business, lived experience, communities. There's 8 learned Academy members on the think tank. Tom Karma, driving force between Close the Gap, Pat Dudgeon, so that First Nations voices and wellbeing and learning are at the heart of it. We don't have a long tradition in this country of building think tanks independently and then fostering their voice. We need to enable connection with diverse voices, particularly young voices when it comes to mental health. And we need new, high-quality, independent evidence that's framed to actually make positive change in policy and in the lives of people. And speak to new engaged audiences, because in mental health the story cannot always be about the deficit. It needs to be what we can do in a positive way, how we can connect and how we can change and how we can have hope. We need definitely new policy impact, and hopefully COVID will allow us to see that. And in the end, hopefully we can change the conversation. We can amplify innovation like Bernie's innovation, like Sally's innovation, and like Liz's innovation. And hopefully mental health think tanks and mental health can bridge policy evidence divides, and we can have exciting pioneering and exciting work happening right now. Thank you.
Thank you. What an inspiring panel. Thank you very much. That observation of yours, Sally, about the failure to implement the recommendations of royal commissions, I think goes to the heart of many of the issues that we're discussing here today. It happens in area after area, and I guess its flip side or its corollary is that there are endless trials which get funded and then fall over, and the lessons don't get applied. So how do we move from that, the knowledge in a sense, to the action which needs to make it real? I'm interested in each of your responses to that, but then we'll go to questions from the audience as well. So Sally, do you want to pick up on that? What needs to be done? What might be done with your... Yeah. Maree, sorry. Maree, sorry.
I'll answer to anything, mostly.
What might be done with through your think tank or some other means to actually see that action coming rather than it just being all the talk?
Yeah, I think communities and connections are going to be critical to that. I was really interested also listening to Bernie say, 5% of your budget or something comes from government? So I'm really interested in how we can mobilise other forces. We do not have, in Australia, we do not have those independent forces that then work towards to mobilise things. Sometimes it's funding, sometimes it's partnerships. That's the first time, for example, BHP Foundation, and lots of different challenges there, has built those partnerships around mental health. I think that is really telling, Bernie, that so few of your so little of your funding comes from government, but it might also be the enabler for us to work to create the change that we need. So.
Liz?
Yeah, I think to get research into practice at the community level really involves co-design. It involves people to say at the outset, what are the important outcomes? And what we try to do is action research so that we're giving outcomes along the way. We're not just collecting data, it's a real partnership. With regard to the hospital system and the implementation of findings from, say, randomised controlled trials, we need a real shift in the attitudes of the hospitals and the health systems to really allowing research to be embedded in the system. And I know the Academy of Health and Medical Sciences has done a big piece of work on that. And of course, to get any research into practice, you need to have the clinicians on board, the people who are going to use it and really get their opinion and get their ownership. Otherwise, no clinical guidelines ever going to be implemented.
Yeah. Sally?
Is it on? Yeah, okay, sorry. It's not my strong point. Perhaps I'm surprised you that I say this, but, I think we have to be in it for the long haul. And I think that requires an honest conversation. So, things, they can't be fixed. We're talking about really complex and endemic sort of problems. So they're really not going to be fixed quickly. And I think we need to be clear about that and to select the most important actions that need to be done. So, you do see, I think it's a great statistic, the one about, was it 50 inquiries, did you say? 53, they all would... 55. They all would have had many, many recommendations. So it's 9,000. So, that... Yeah, so that's really sort of challenging to get your head around. So I think you need to need to start asking what is the most important thing to do. So I've been really impressed with, kind of discussions recently about systems thinking and how we can best apply that, because it recognises the complex intertwining of many of these factors, and then it starts to let you think about where the critical points for change are. What would be the most important thing? I think that's what Bernie was talking about, actually, and I think that we could do well as a community to have some dialogue around that.
Bernie, your insights. I mean, one of the big things of yours was breaking down those silos, wasn't it? I mean, that was a really crucial.
Oh, the silos.
Yeah.
I think we heard Alison talk about it.
Yeah.
I think we're pretty good at defining these things. You've got 9,000 recommendations, of which we can't put one in place. I think we get stuck in the big, complex, can't do it, it's just too hard, sit in the corner and have a cry. We don't do it like that. This isn't a question of why can't you, how can't you, it's a question of how can you. And when I look at the 8 other communities we're in, you want to talk about a complex problem, try and replicate what we did. You want to talk about a complex problem, ask the 6 universities when they first bounced into Armidale and went, hey, I'll tell you what we're going to do. We're going to write this paper. We want to get some runs on the board. We're just going to define what it is BackTrack does. Should take us a month. 6 academics, professors, all the smart guys. 12 months later, mate, tearing each other apart, going, well, what do you mean? It's just for kids that are 12 to 24, yeah? I go, yeah, but if there's a kid that comes in at 11, well, we'll sort that out. So we're constantly going, how can we, not how can't we? And I think when you start doing that, one of my favourite sayings in the world, after action comes clarity. Jump off the damn cliff. I scare the Jesus out of people going, oh no, here he goes again, what crazy idea. But if you don't just jump sometimes and do stuff, then you're going to sit around defining the damn problem, worrying about how you can't do it. It's too late. We've got 9,000 recommendations to implement. Which one are we going to implement? Tell you what, implement one. Just start with a damn step. That's my opinion.
Okay, thank you. Now, questions? Does anyone want to do? No, people being timid, being nervous, being shy. There must be. Yes, thank you. There's a microphone here in the middle row.
Hi, I'm Renee Ryan from the University of Sydney. It was an amazing session. Thank you to you all. My question's for you, Bernie. With your program, you talked a lot about boys and young men. Are girls involved in the program, and do they have different issues? How do you deal with that, or is it specifically for boys, the program?
I spent a lot of years in Central Australia, Tennant Creek, Warramunga Mob. When I saw what beautiful things was going on in Central Australia with the men and how they started taking care of the kids, I know there's lots of dysfunction and tough stuff, but when you see the beauty of it, when you go to Fitzroy and go, man, when you look for the gold, you don't have to look very hard to see it. So when I came back to New South Wales, it was kind of designed on that. I've spent years and years in remote communities and knocking around with the countrymen, deepest of respect, and they taught me stuff that I went, you know what, how simple is this? How simple is this? Those people deal with grief and loss better than anyone in the damn world. And when you start to feel some of that stuff, you go, boy, that's what it is. So when I came back and we started with the shed, it was all very manly, but that was the drive and the passion was to do something with these kids. And at the time, it was all about these young fellows running amok and what do you do? And felt like good swim lane for us. It was mostly blokes that were down there volunteering when we were starting. So we really designed it and went on just specifically for boys. We've had a couple of goes with the girls. We have definitely had girls through some of the girls' work in the BackTrack work side of it. It's always around people when you get the right people. And I don't want to be running a girls' program as a bloke. But when we've had really good strong female staff that go, you know what, we've got to do this, then I go, happy to get out of the way. I'll find the funding. You do it. So we've had different areas of it. You asked me, does it get hard? Holy smokes. I don't know if it's the same in Sydney, man, but when you put the boys and the girls together, something weird happens. It all changes. It gets very tricky. Will we go there again at some stage? Sure. I'd like to see it on a different site, though, because, man, it drives me mental. I can't work it out.
Yes, down the front here.
Thank you. I'm John Myberg. I'm a professor of intensive care medicine in Sydney, and I run a research institute to do large-scale clinical trials, particularly in intensive care. This has been a fantastic session, and it resonates across the whole spectrum of healthcare. And a couple of things I wanted just to highlight or ask a question was the access to funding for national priorities. Because the current funding model, to use Bernie's phrase, is broken. I could be stronger. I could be stronger than that. We are living in a bottom-up competitive funding model where the attrition rate of researchers and questions just gets lost every single year. I sit on research panels and I weep when I see the projects that get cancelled and people get lost in the translation. And one of the successes of the pandemic came out of the UK, where the national portfolio of research designed targeted areas for the community to address and got the researchers to tender for those jobs. It's a reverse model. And surely it's time in this country that we did the same thing. We've now got community engagement, we've got Indigenous people engaging in questions. The mental health issues that you've raised, Maree, are for the forefront. Surely it's time now, as part of all these academies, to get a nationally funded body to identify areas of research and key clinical questions based on the innumerable inquiries, and put out one or two issues, as Bernie outlines, and get the institutes to tender for those jobs, and then produce an output as soon as possible, rather than the bottom-up approach. I think it's high time that we did this in this country.
Thank you. Would you like to comment on that?
Yeah, point incredibly well made, because where will the innovation come from in this country if we keep losing the creativity, particularly in the research space? That's an incredibly important point. I just chaired the Million Minds mission for the Medical Research Future Fund, which was like $60 million over the next 5 years. It costs more to put the sign up out the front here. So I 100% agree with you, but we have to start creating those models also within an Australian environment. So what is the business case for putting those models up? It'll be very different here from the UK. UK has a lot more philanthropy and a lot bigger tradition and a better way of funding their researchers within universities. They just laugh at our system. It's like a house of cards. It's all just falling over. MRFF does not, Medical Research Future Fund, for those people who are not like living in medical research, which is an amazing $900 million a year fund. That's what it's supposed to grow to, but it doesn't fund the people. It funds projects, so we just keep lumping projects on. So I 100% agree we need new models, and I'd really like us putting up, I'm literally working on one at the moment, for a business case for these types of institutes that you're talking about, or a network of institutes, because we could. So I'd really love to talk to you about that. I've got one right now on mental health, and we need a network of them. I don't think one. So that was my answer. 100% agree, yes, let's do it. And any academies want to talk to us, let's get that happening.
Yeah, go on. Yes.
Just to add to it, I would say I 100% agree as well. But if you think about like co-production work, then you really need to recognise the fact that it's resource intensive. You need to have resources to be able to set up communication, governance models. Takes longer, and the value is as much in the relationship that you build. So as long as we keep having 3-yearly or 5-yearly injections of funds, then we're never going to be able to work effectively with communities.
Yeah, I mean, I think that the point that several of you made is it's about that capacity building. It's about the leadership capacity building as well. And I think that the part of the thing with the research model that we have at the moment is, as you say, it's very competitive. Enormous amount of effort goes into writing applications. Very small percentage get funded, and so you're missing out on that capacity that you're following. As you say, you follow the person through to build that capacity that they can then have that impact, and that applies in academia, it applies in communities. I mean, if people get churned through that and don't get that support, you don't get the chance to grow it as you've done, Bernie, in your job. Yeah.
Could I just add a comment to that? Just listening to what you say, I go, I'm not afraid of copying things that work. In fact, happy to do it quick bit of plagiarism. If it works, why not pinch it and use it? If there is a better model, whether it's in the UK or whatever, why aren't we just copying some of that stuff? If we know what we've got's busted and we've got something across the fence that you go, oh yeah, that kind of works, why aren't we doing that with incarceration? Just trot over and have a look at Finland and Sweden and going, man, they're working out what to do with these big buildings now that they've closed them down, because there's only 2 or 3 kids in a whole friggin' nation that are locked up. I go, why aren't we just trotting over there and having a little bit of a look at what they do? Heaven's sakes, you know, our funding model from Canada. In 2014, went over there. I mean, trotting around. It was the Gillard government first helped us out, going, oh, right, you come over here with this model that we've looked at where we just go 49% government funding, 51% private funding. Let's get on and do the job together. I go, why don't we just copy some of that stuff? Seems to work.
Okay. Question down here. Second from the front row.
Tony Cunningham, I just want to comment on just what was raised here with the UK. Israel is another example of a country that moved really quickly in COVID. We did some good things, there's no doubt about it, but Israel moved incredibly quickly and was able to link its best academic institutions from Weizmann through to government in order to get their advice to the politicians as quickly as possible with a COVID czar and implementation that moved really fast. I was lucky enough to be one of a group of 19 people in a mission to Israel recently, which included 2 of our state chief health officers. So I think this concept of leanness between academia and government and a very short number of people linked in that chain is really important. They also put their findings out immediately. They weren't subject to politician control, government control, so that the community could actually see what the advice was and would hold the government to account. We can learn, certainly, from overseas.
Thank you. Yes, being adaptive, I think, is one of the should be one of our strengths, and it has been from time to time. There's a question, the final question at the back, the guy in the back row there, I think.
Thank you. I'm Jin from UTS. So I also run Active UTS, which is a student organization, not-for-profit, that serves all the clubs and run all the programs. So listening to all the conversations, for the past 2 years as a student, what I see is there's increasing challenge in mental health, obviously. So this is an issue that I face and most of my friends face. So did some stakeholder communication and I figured out why don't we have a mental health first aid program. So we did that. We started a mental health first aid program. It's actually coincided with it's like a CPR, but it's on mental health. But if you consider CPR, the statistic I learned is 99% of people learn CPR but never used it in their life, which is a good thing. But for mental health, even in my few years of experience, you encounter a lot of emotion, run high stake, run high conversation with a lot of people, especially in student community. So in the past few years, student reaching out to student each other, it's a peer-to-peer connection where you have challenges, but I have nothing to say to them. I don't know what to say when they ask me, I find this challenging in life. All I can say to them is, things will get better, but back in the days when looking at the COVID number, all things is not getting better. So then we start this program. So I was wondering, I know the conversation here is very high level, but throughout your researches and everything you've done, is there something that I can implement? This is Tuesday, so I can take back and implement this Friday, and that don't cost much money, but it's as effective and useful to students, as useful as, let's say, a mental health first aid training for students. Is there something that we can do? Thank you.
Okay, that's one for you, Maree.
Yes and yes. Yeah, talk to me at lunch, 100%. And mental health first aid, you know, it's great, but we are also a country of telling everyone, are you okay? And then not having anything to follow up with it afterwards. So I think that's great, and I'd really like to talk to you about what you can do after you start that conversation. But it also does require a lot more investment than we put into this space. I mean, we heard that amazing story about teachers, our health workers. They are under incredible pressure at the moment. The pandemic, so I do think we have to do a reality check about it isn't just asking, it's about what we need to scaffold to help. How do we upscale all of these amazing projects? Anyway, yep. But at lunch.
Well, that's one of many lunchtime conversations. So I would like to ask you to join me in thanking our panellists for...
Could I just make one quick comment before lunch? My brother's also a university professor. We're always arguing about stuff. That's how we got the research going. When I'm with the kids at the shed, I go, you got any questions? And they go, yo, where you been, man? I get that. When my brother says, can I ask you a question? I go, right, you've got 25 minutes and I better understand what you're talking about.
And I gave your brother his first academic job.